few of these conferences over the years, so maybe that does qualify me to be a veteran of the conference. And I think most of them, all of them have spoken about feeding difficulties. I think it's an area that is common for all of your children to have some difficulties to varying degrees in. It was lovely when I came in earlier and it was lunchtime and all your kids were in here. And there was a real range of ages, and there was some little babies, and there was some older children, but everybody was here, and everybody was having lunch together. That's, I guess, for you guys, is your ultimate aim, for everybody to be able to be in the same place and have a meal together. And I don't think that is very much for us to ask, but it's not always achievable. So we're going to talk about why your children may have these difficulties, what these difficulties are, and then obviously the thing you all want to know is what can we do about them, and what are the chances of affecting some change for these children. Okay, so this is who I am. I'm Rebecca Howard, and I'm also from the Children's Hospital in Manchester, so I do see a lot of children with a wide range of feeding difficulties. Some of them are children who have a diagnosed syndrome, some of them are children who have been in hospital currently for various reasons, some of them we don't know why. Okay, so I'll try and cover, it's about feeding and a little bit about swallowing, but probably mostly about aversive behaviours, because I think that's probably where your interest is going to be. I'm going to talk a little bit briefly just about why you get to the position you're in, just to try and reassure you, because I think lots of parents who speak to me, I do have to reassure them that it's not something you've done, it's not your fault, it's not something you haven't done. It's just a set of circumstances that has led you to be where you are. So it was very interesting hearing Steph talk earlier, so talking about her experience of her fourth baby, who she went from a home birth to that lovely home-based birthing to a hospital, cesarean section, NICU, skidoo baby. So maybe your children were like that, maybe you had to go into a neonatal unit when they were born. So if they did go into a neonatal unit, well, did they have to be fed by a tube? So was that tube in their mouth? Was the tube a tube in their nose? So already you've got these poor babies who are used to just being cuddled next to mummy, then suddenly they've got tubes and bright lights and all these reflexes that they're supposed to have, so sucking and nuzzling, are really for their self-preservation. Sometimes the children might start to shut down a little bit because they're overstimulated. We've been talking a lot in the previous talk about overstimulation. So self-preservation may already be starting at that point. Yes, your babies who have Costello or CFC syndrome may have a weak suck because they have low muscle tone generally. So, it takes them a bit longer. They are not lazy feeders. So people say that, people still say that, and nurses say, oh yeah, they're just a lazy feeder. Babies aren't lazy feeders, they feed slowly for a reason. Whether it's that they have a heart problem, which means they get tired, or they have a weak suck, or they have reflux, so they only can have a certain amount in their tummy at one point in time. So they feed slowly for a reason. All these difficulties are then further compounded by the fact that you may be having to be fed via a tube, and people in neonatal units or on maternity units like the babies to be fed 2 hourly preferably, or maybe even 3 hourly if they can, because that's easier for the nurses on the wards to work around. But newborn babies don't typically do that. They don't really like to be put into that set routine of having 60 mils every 3 hours. They might be feeding different volumes at different hourly times. So already we're imposing an unnatural routine on these babies. So that's maybe why you've got to the point that you're at. So I just put this picture up. So this is one of the babies that I've been working with recently who does have a rare genetic syndrome, not one of not Costello's or CFC. So this is a baby who is nursed in intensive care. So very complex medical condition. So the baby's got a feeding tube in their nose. They've got actually tracheostomy, so the baby's ventilated. And this mum, we got this baby I didn't believe we would. We got this baby to be fully breastfed. Okay, we didn't need any tube feeds, baby weaned beautifully, and all the feeding tubes were removed by about 8 months of age. So this is what we started with. This is the baby's asleep, isn't she? She's looks lovely, happily, and swaddled by mum. But actually, this was what we did, and mum was adamant that as much as it was a bit of a practical nightmare to do this every 2 hours on intensive care, the nurse looked at it as if we were mad. They go, oh no, I've got to go through 2 of us to get baby out, to put her on mum's knee. And mum was expressing breast milk, but mum would then put baby next to her just after she'd expressed or before she was due to express. And she did this religiously, probably for certainly about 3 or 4 months that she was in the intensive care before she went to a different ward. Mum was able to remain very calm and relaxed about it, because this is all really that happened in those first 3 months. The baby didn't latch, she didn't really make attempts to suck, and I'm thinking, well, it's fine, it's good, because it's stimulating mum's milk supply, and it's all a nice experience. And then suddenly, over about those 4 or 5 months of age, baby suddenly started being more awake and actually started rooting and looking like she wants to be fed. The tube feeds weren't as regular, so there was more time in between feeds, and then baby started breastfeeding. It did teach me that nothing's impossible, I suppose, from that experience. So if you know people who are in that neonatal experience, then really get them to fight for pursuing with those types of activities. There's a lot of, I've got it on my next slide, there's lots of work now in neonatal intensive care about promoting opportunities for oral feeding or for oral stimulation, whether it be dummies. Okay, I've got some information about that, I won't go into it in too much detail, but if you do know anybody who's currently in that situation, then there is a lot of research that's used in America to talk about why the outcomes that you can achieve just by doing lots of early intervention at that age. Okay? So we can talk a bit about what problems can be contributed by. So we talked about early experiences. So we've got feeding tubes in the nose, in the mouth, suction, oral suction, nasal suction. It's not a pleasant experience for the baby. Got reflux, which is overt, that's obvious, that's the babies who vomit as soon as they're moved. But also, we shouldn't forget silent reflux, so that's the babies who are uncomfortable after feeds and nobody knows why, or they think it's a bit of colic or a bit of wind, but maybe it's a bit more than that. It's actually silent reflux, which is causing them discomfort, and it's just teaching them a negative association with feeds. We've talked about reflexes, so our feeding reflexes, which are naming and rooting, so that's when the baby's searching for a feed, and sucking is actually the actual process of extracting the milk. So we know they're going to be weaker, so it's going to take them longer, but that's not impossible to overcome. And we talked about the tube feeding regimes. Sometimes the babies will either be on 2 or 3 hourly feeds, or they might even be in a continuous feed, because you can get a nice pump, can't you, and just put a feed up on a pump on the neonatal unit or on the ward, and then the nurse can go off and do some other things, and that baby's being fed. That's not a natural way to feed. We do have missed opportunities, which are only missed in terms of it becomes more difficult to re-establish bottle feeding, to establish weaning, to establish a child to take lumpy food. So although it's a missed opportunity, it doesn't mean you will never get there or you shouldn't try, it just means it is becoming more difficult. Just to show you a little an X-ray still, so this is a child that so if we're concerned that a child has a swallow, we probably will do an X-ray of their swallow. So just to illustrate reflux, so this is a child who came in for assessment, so they're not eating, they're not swallowing, they're refusing feeds. So actually when we do the X-ray of the swallow, so we can see here, the first circle here, that's the spoonful of food going in. The black bits is the food, so there's already a mouthful, there's still a mouthful of food in this child's mouth. Actually, what's happening here, the child is refluxing, and some of that reflux is being aspirated. They've still got a mouthful of food, and somebody's feeding them another mouthful. Okay, and you wouldn't have known that. To look at the child, actually sat in the chair feeding, you wouldn't have known that was happening, and that's probably why we got to the point where they were refusing feeds, and feeding time become a battle. Okay, so just be aware that reflux does cause a lot of problems, and if you think your child is unsettled with feeds, or even if they're not vomiting, then please speak to your doctors or paediatricians about that, or your dietitians. So talk a little bit, very briefly, I think most of the children here are slightly older, about dummies and the use of dummies. Some parents would prefer not to use dummies, but it's something that if you have a child who is requiring tube feeds, we would offer that as a treatment for you for promoting oral reflexes, and if it gives us the opportunity to respond to their feeding cues. So a child who can't have any milk feeds orally yet, but we could give them some dummy stimulation. Okay, so that's there and that's available, usually in a neonatal intensive care unit. We have mentioned missed opportunities, so like I say, there's lots of research from psychologists to talk about missed opportunities and windows of opportunity, which is what they're quite often called. They're based on normal development, so what I would say is try not to look too much at those ages that are given for these windows of opportunity. Think about your child, as the person that your child is, and what stage of development your child is. It's a bit like I say to parents who, if they're buying baby foods, for example, they'll say, well, so-and-so, they're 12 months old now, so I went and bought the baby biscuits that say 12 months plus. Right, okay, but let's look at your child and let's think about, are they behaving like a 12-month-old? And if they're not, then we need to move away from using things or looking at developmental norms, and look really about what your child is doing and what they're able to do, and making it as easy as possible for them to succeed. So these are all the windows of opportunity for feeding and the feeding developmental milestones, but they are based on normal development. So we've already seen that 3 to 5 months is the best time to introduce new tastes, but maybe your children are still in hospital at that point, so you didn't have access to making your own food, potentially. You only had access to what the hospital were able to give you. And also, nowadays, certainly in the UK, the guidelines for weaning are not to start weaning until 6 months of age. So that would be lovely if anyone wanted to exclusively breastfeed and were able to exclusively breastfeed to 6 months of age, and then on one day when your child is 6 months old, then you start weaning. Okay, but it isn't like that for most people, I have to say. And from 6 months of age, it is potentially going to be a little bit more difficult, even with a child who's not been in hospital and has not got developmental difficulties, to establish weaning as easily as if you started a little bit earlier. It's like anything. The more children taste something, the more they like it, or the more likely they are to accept it. What they might do is they might refuse something, so you stop offering it because you want them to eat, because you want them to be weaned off the tube. So you'll only offer them the things that they're accepting. Okay? In terms of textures of food, so moving on to lumpy foods, so not just purees. Again, this is all in normal development. We usually start at lumpy foods only about 7 months of age. That's the baby products you get in the supermarkets. The research would say that it is important to introduce those lumps before 10 months of age. But actually that's 10 months is because the child's more likely to be sitting up without support. They're usually putting their hands to the mouth quite easy at that stage. They've developed oral skills, which mean they can tolerate and manage those lumps. So that's why it's 10 months. There's not something actually going to happen at 10 months of age if your child's development isn't at that level. Okay, so as long as you're introducing lumps at an appropriate time for their development. If anyone's got to that age of 18 months, 2 years, then the toddlers who suddenly hate everything. So all these lovely foods that used to cook them when they were 6 months old, they would eat happily. Suddenly they're disgusting and they're not going to eat anything that's green, and they're not going to eat that, and they're not going to eat that, and everything is horrible. That's a normal phase as well for children to go through. And that can actually continue for quite a long period of time, and sometimes it's not really until your children get into school where you start to make inroads into that, because they see the children eating and they start to try different things, and actually they don't get substitute foods offered to them like they might do at home. What I would say is that there isn't an age point at which I would say, or anybody would say, right, you've not achieved any oral feeding by 2 years of age, okay, we're all going to give up because that's it. You've not achieved it by 2 years of age, there's no chance. There is no point at which we would say it's not worth trying. What I would say is that it gets harder. So the older the child is, and we're trying to establish weaning, or we're trying to reduce some of the tube feeds, it's going to be harder, but it's not impossible. I don't know if anyone's had that told them by anybody. I've certainly heard parents come to me and say that they were told by a medical professional that if they hadn't got their child eating by 2 years of age, they were never going to eat. Well, that doesn't come from any research anywhere, so please keep trying. If you feel there's reason to keep trying and you want to, then there is no age limit where you shouldn't be trying. So in terms of treatment aims, I try to think of what you actually want. So if you've got a child who is tube fed, then if that's because they've never established oral feeding and they've never been weaned onto solid food, so they are now in this category of aversive behavioural feeding difficulties. Actually, I don't think it's very complicated what you want. I think you just want to reduce that aversion, and you want to ideally eliminate it, which then leads you to being able to wean tube feeds, to reduce tube feeds, and ultimately get rid of tube. And that means that you can all have a mealtime experience together. So I don't think it's complicated what you want, is it? I don't think that's unreasonable to ask for. I think that's what most people in your position would be asking for. So it's not unreasonable, and it's not complicated as a request. It's complicated for how we're going to achieve that, which we'll talk about, but it's not unreasonable at all. So what we are very good at, I suppose, as medical people, is dealing with this bit of treatment. So we're quite good at dealing with the mechanical and the functional problems that we encounter. So from my point of view, that would be assessing and managing the swallowing difficulties. So if a child was aspirating on thin fluids, they were going down the wrong way, then we can treat that. Or we can avoid fluids completely, and we can just look at solid diets. If we have the problems of reflux, then there are medications that can manage that. There are feeding regimes that can manage the reflux or eliminate the reflux. There's other areas like constipation, where again you can look at fluid regimes, you can look at medications. But even if we are managing reflux fairly well, keeping on top of it, quite often what the doctors say, let's keep on top of it, and keeping on top of constipation, then they will affect appetite and hunger. Okay, so even if we're just about keeping on top of them, it's still not a great state to be in terms of enabling the child to accept anything orally. So if you think you've got a child who is prone to reflux or constipation, then please make sure somebody is looking at that regularly, because it makes my life and the people who do my job a bit more difficult if we're running into problems in those areas. What we probably do struggle with a bit more is then treating the other side of the feeding difficulties. And I think certainly most of the children that I've come across with Costello's and CFC probably don't have those mechanical difficulties. They might have a bit of reflux and constipation, but we're not dealing with a massive mechanical problem, so we're dealing with all the behavioural aspects of feeding. And that's where you probably find it difficult to get somebody to help you, I'd imagine. So it generally would fall into the realms of psychology, having some input as well into those children, those areas of difficulties. And the problem then you also have is there's lots of different opinions of psychologists. I've just picked out two. I've only picked out these two psychologists just because A, I know some of their work, and B, I know some children who have gone through both those processes, so that's why I've just picked out these two, and they're both quite different in their approach. So Marcus Wilkin, who is a non-UK based service, his philosophy is a hungry mouth learns the necessary skills very quickly. So if you stimulate hunger or provoke hunger, then the person will start eating. But that would be wonderful, wouldn't it? If that was so straightforward, that would be wonderful. Okay, and it is maybe some children will look at why that can suit some children. The other psychologist I've picked out is Dr. Davey, who is based in the UK. He's based at Stafford University and just offers some NHS services via commissioned services. And he would say that you work on oral skills and reversing oral aversion before you then provoke hunger. He's not saying you shouldn't provoke hunger to then stimulate oral intake, but you need to work on oral aversion and oral skills first. Okay? So already I'm a bit confused because they're two very different ways of working. Just to talk very briefly about Marcus Wilkins' intensive food feeding tube weaning process, he does have some contraindications for criteria. So obviously one would be if you've got a swallowing problem, i.e. you are aspirating and you couldn't swallow food or fluids, so it's unsafe, so we're not looking at weaning off a tube in that situation. If you have a medical condition that conflicts with fasting, so restricting food intake, oral feeding, which is aspiration, or these are his words, or would allow the child only to eat unpalatable nutrition. So if they had a medical condition where they had to follow a very strict diet, so sometimes that being a metabolic disorder where they had to eat certain levels of protein or reduce carbohydrates, so they wouldn't be able to be put in a position where we're restricting their intake. And if their body mass index, so that the weight-height proportion, was below the 10th percentile. Okay? And psychological conditions that would contraindicate an intensive tube wean would if the child's state allows no stress-inducing treatment. Okay, so does that mean there is going to be some stress-inducing activity happening? The child is going to be fasting, and they're going to have to self-regulate their behaviour in response to that. Okay, so there are the contraindications for doing an intensive tube wean. So his tube wean that they would offer would be a preparation period, which is 1 to 12 months, which is probably what we would do in the UK, what you would be receiving is from therapy services. So it's food play, messy play, all those types of introduction to food that you would get anyway. And that generally, from what I can gather, is done via video links and conference calls. There is then the period of hunger induction, so it's reducing tube feeds over a period of 1 to 5 days. By day 5, the idea being we're on no tube feeds, and by day 14, we are on enough oral nutrition and fluids to mean that the tube is not being used. Okay, so something's happening in that day 5 to 14, which means the child is starting to eat orally. And then they offer a 6-month follow-up. Okay? So, if we look at hunger provocation, because that's what would be wonderful. If that worked, that would be wonderful, make all our lives easier. If it was something that could happen very quickly, then Dr. Dovey, who is a UK-based psychologist, he says it will work, but it only works on these set criteria. So I won't read through them all. I think if you just read through all those different points, I can't think of any child, other than one child that I've worked with, who did go to Dr. Dovey and had a successful tube wean, but I can't think of any other child that I've worked with who fits all those criteria for intensive hunger provocation. Okay? So I thought that's quite interesting because it's ruling out most children with feeding difficulties for all those reasons. Okay? So what we would look at is looking at a programme based on this principle. Okay, so this is called the 32 steps, I think it is, 32 steps to eating. Okay, so this is the number of treatment aids you may have to go through to get to the point at the top, which is the eating point. Okay, and I think, again, we're quite good as speech and language therapists or occupational therapists, play therapists, at working on the tolerating and the interacting with and the touching, maybe even the taste bits, but we probably get stuck quite low down on these steps. And actually what you want is you want to be at the top with some eating. You don't want to be playing with food forever. Okay, so that could be a treatment profile that we used. It's come from, if anyone wants to look that up on the internet in more detail, it comes from an approach called the SOS approach, which is American-based approach that is used, and it is very regimented, but it does work in lots of cases. I'll talk a little bit more about that in a minute. Okay, but it is working through each one of those steps one by one, and for each texture. So you might do that for fluids. You get to the top for fluids. You have to go down and do it all again for puree. And you go down and do it all again for biscuits. Okay, so to get to a full diet might take a reasonable period of time. So that would be looked at as more non-intensive treatment, and it's certainly not hunger induction. So we probably thought that hunger induction is maybe not a great idea for our children. So we want to do something. So we're going to look at this non-intensive treatment, when it's not going to rely on making the child hungry, and that should be provided for people here from the UK. It should be provided by your NHS services, and there should be a collaboration between people like myself, certainly a dietitian, your paediatrician, and ideally a psychologist. That might be difficult for some people, but that's where it should sit, and it should be provided. And just some quotes from Dr. Dovey. So, for children with feeding problems of clinical significance, it's unlikely that change will occur without professional intervention. Well, yes, you probably realise that. And the etiology, so the cause of the feeding problem, is likely to be multifaceted, for lots of different reasons. We've talked about that, and requires a complex and highly consistent management strategy to elicit change. That's not saying anything that's rocket science, I don't think, but actually what you want is somebody to do that for you. And to accept a new food item may take between 7 and 20 taste exposures for a typically developing child, and over 35 in, and I've just thrown a term in here because I don't know if anyone's heard this term before, avoidant restrictive food intake disorder child. Okay? Which is maybe where your children might sit. Has anybody heard of that term before? It's a sort of new term on the block in the last few years. It's come about to try and categorise the children who haven't got a physical reason why they don't feed orally. They are refusing food based on the sensory properties of the food, or their previous experiences with food, but they're not refusing food for issues like body image. I think it was devised to try and capture this group of children. They're not anorexic, they're not bulimic, they're not fussy eaters, they're not being naughty, they're not being problematic. They are refusing food for a reason. Okay, and this new term was, well, it says it's 2000, it's actually only accepted as a psychiatric diagnosis a couple of years ago. So it's an accepted diagnosis now. I don't know whether that helps parents for having a label that you can use, because quite often people would refer to your child as a fussy eater. Well, they're not fussy, they're avoiding food for a reason, which is probably quite a sensible reason in their minds. So it's an accepted psychiatric term now, and may well mean that if you're looking to apply for any commission services, if you could get that term used as a diagnosis, it potentially helps you if you're applying for services. So just a little bit about, this is the wording that they use in the description of this term in this psychiatric descriptors. So the important thing is that it's an eating or feeding disturbance, such as a lack of interest in eating or food, avoidance based on sensory characteristics of food, and there's concern from the child about aversive consequences of eating, and it's persistent failure to meet nutrition and or energy, and the child has to display significant weight loss or faltering growth, nutritional deficiency or dependence on enteral feeding or supplements, which is, I guess, where a lot of you guys might sit, that you're dependent on cheap feeds, for example, or on supplement drinks. And it does have an interference with your social functioning and the child's social functioning and development. Okay, so it is there as a diagnosis now. So I don't know whether that helps people to have a name and a term, but it may well help you if you're looking at services and getting services. And again, just some advice from the team who might work with children who've got this avoidant restrictive food intake problem. So the best advice in the primary health care, so you don't need to come to hospital to do any of this either. So this should be done in your home setting, in school, in nursery. So you should have a calm, relaxed, fun, non-pressured, but repetitive environment where the focus is on the whole context of eating. Okay, it's not about how much they've eaten or how they ate it and how many spoonfuls. Okay, again, that's common sense, that's nothing new. What we wouldn't advise is a time urgent, target-driven meal time. Okay, so that's right, we've got 20 minutes and you've got to eat this bowl of food, and you're not leaving until you've finished it. And the child is already hungry and they're scared of food and they've never really eaten food before, so that is going to set the child up for failure. And all those things that Dr. Lloyd was talking about in the previous lecture, about it's anxiety-inducing, if they can't communicate with you, that's how they feel around food, but you're imposing this regime on them, then really, is that fair? I wouldn't want that to be imposed on me as somebody who's had normal feeding development. Okay, so we talk about how we're going to achieve some of these treatment aims. So our aim is to improve that oral aversion so that the child does eat more. So remember our steps. Okay, so these are our steps to eating. So what we want to do is get to the top of the steps. So we want to get to the bit, if you can see under taste, or above taste, it says chews, swallows, some and spits out, and then it says chews, swallows, a whole bolus. The bolus is just a piece of food. With drinks, it might have a drink to wash something down. Chews and swallows, a whole bolus independently. Okay, so when you're getting to that type of point, particularly getting to the point of chewing and spitting out, okay, which tends to be a point at which we get stuck quite a lot. So when we get to the point of chewing and spitting out, then maybe what we need is a nice dietitian who, or probably a dietitian who's experienced in paediatrics, who has some confidence in negotiating some aims. So if it was me, I might be saying, okay, I'm at the point where this child is now accepting food into the mouth, they're chewing it, but they're spitting it out. Can we just look at a little bit of alteration to their calories and a little bit of alteration to a tube regime, if they're on a tube regime, to see if over time that means they stop spitting the food out and they start swallowing, because we've stimulated a little bit of hunger. We're not going to stimulate that intense hunger that we've talked about. We might stimulate hunger a little bit once we've got to a point in those 32 steps where we're almost there, but we're stuck. Okay, and typically dietitians aren't very keen to do that, but I've found if I've sit and explained to them that there's clear exit strategy. So the exit strategy might be, we'll do this for 4 weeks, because it's not going to be 2 days. Nothing's going to happen in 2 days, but can we try this for 4 weeks? But if before that point in time they've lost X amount of weight, or their fluid intake has been poor, or they're concerned about how hydrated they are, then we'll stop it straight away. Okay, so we might negotiate, and my aim would be to negotiate at that point with dietitian or whoever's responsible for their tube regime to manipulate it slightly. But it does need to be for a specified time, and that time is weeks, it's not days. Okay, so that, I think, is the point. That can be a sticking point for some people, but I've certainly done that with some of the dietitians I've worked for. And again, like I say, you might do that for fluids when you get to the top of the steps, but then you've got to repeat it for lots of different textures. Okay? So to look at, in fact, I'll look at some of the outcomes that some children have achieved following some of these treatments, which shows that you can make success, but it's a long journey. So what this slide shows, we've got start of therapy. So this is start of treatment. The child's observed just doing what they would do normally with food. So they tolerate, so if they're looking at a puree, they would tolerate the puree 100% of the time, they touch it 100% of the time, there's 0% tasting and there's 0% eating. Okay, because we differentiate between tasting, which you might be spitting out, and eating, swallowing. That's happening 0% of the time. End of therapy, child entered, so end of a 6-week block, which this one was, then the tolerating and the touch stay 100%. The taste has gone from 0% to 29%, but eating stayed the same. They stayed at 0%. So actually, if it was tube feeding, it wouldn't have made any difference, because although they were tasting more, they weren't swallowing anything else. But what they'd also look at in this treatment is what they call with therapy assist. So rather than leaving the child to their own devices with a bowl of puree, if you are assisting the child, so you're prompting them to eat, when you're prompting them to put the spoon to their mouth, and you're doing that consistently over that meal time, what difference does that make? And what we see here is that the taste goes up from 80% before treatment, because they're having some assistance anyway, to 85%. But before treatment, they weren't eating, they weren't swallowing. It was 0%, and it's gone up to 29%. Okay, so actually what's happened is, before, if you look at the child entered side, what the taste, 29% of the taste has moved over with prompting to actually eating. Okay, so 29% is a pretty good increase, I would say, over a 6-week period. So you could get, if you could reduce your tube feed by 29%, then that's something to, that would make a difference, I guess, for some people. So that might be a sort of plan that somebody would follow. And over 6 weeks, this was a child who had some learning difficulties. It wasn't my patient, but I just know the outcomes. Who had moderate learning difficulties, had autistic spectrum disorder, and was relying on tube feeds. Okay, so after 6 weeks, we got to 29% increase when they were prompted to increase in their actual food swallowed. Okay, so that's one outcome we might achieve, and one treatment might do. what they also look at, before we even got to the point of actually making the child or recording what the child is eating, is looking at stopping the child refusing. Okay, because I think maybe you get into the habit of, you think the more we offer the food, then the more chance there is that they'll accept it. Well, actually, if they're offering something and it's being refused all the time, or are we just continuing that cycle of food refusal? And I think, like Dr. Lloyd was saying previously, basically you're just keeping your A, B and C the same. So you're making the same food, sitting the child in the chair, offering them in the same way, and they refuse it. And you're keeping that all the same, and it's never going to change. So how are we going to change? What we want to change is the food refusal first. So what we look at in this chart, which went from November, the end of November to the beginning of January, so that's how many weeks they worked on eliminating food refusal before even looking at accepting food. So actually, the blue line at the top is calories offered. So we're looking at and the red line at the bottom is calories taken. So we see at the beginning there's quite a big gap, the big gap between the blue line and the red line. And what the aim was to get that gap smaller, so that most of the food offered was taken, rather than this being this offering food, refuse, oh, every now and again it's accepted. We want to have a more consistent response to food being offered. And that might mean you offer less food for a period of time. And again, the periods of time aren't days either, which I think is quite hard sometimes for parents, because and I can get it, you lose motivation, don't you? Because there's been lots of things that you've tried when it's come to feeding, and lots of things don't work, or work for a few days, then they stop working. And you don't know why, it's frustrating. But I think what it shows us is that to have something that is going to change to a point of significance, we're looking at weeks and weeks and weeks of work. It's not going to be something that happens particularly quickly. And so by the end of that period of time, there's still a little bit of difference between the food offered and the food consumed, but not as much at the beginning. Okay? So I think what we can say, I don't want to be despondent at all, but I think we do understand about feeding difficulties in your children is that they're more likely to be aversive or avoidant in nature rather than all those mechanical problems. That's probably where we're going to sit more, I think. And they are going to be due to lots of different reasons, not just due to one thing, and it's nothing that you've done. Are our children suitable for intensive tube weaning or hunger provocation? Maybe not, probably not, but it's there, out there as an option for some people. But we know that whatever we're going to do to improve these child's feeding needs to be by lots of people working together, and might need people to negotiate and some people to just think outside of their comfort zone a little bit, particularly regarding feeding volumes and calories. And it is going to be a long process, but there isn't any evidence to say that you shouldn't try at any point. But it's as all the roads that you're on are, it's a long road. It's a road where you're going to be taking steps forwards and taking steps back, but it's not to say you shouldn't be on that road and trying. And certainly myself or other people who work as I do would be supporting everybody who is there and is prepared to try it. But I think it's just about being honest at the beginning, making you realise what the likely achievements are, what the likely timescale of achievements are, so that we're all working towards the same things. And nobody's going to be thinking that there's going to be a quick fix solution, but there may well be a solution there out there somewhere. Okay? So if anybody's prepared to start that journey on that path, then willing to support people, whatever, however difficult that may be. Okay? And that was all. Unless anybody had any questions?